Let's switch gears and talk about the top technologies in the fetal cardiac imaging, and it's going to be 3D and 4D. So I think that it's generally perceived that the 3D and 4D is something very sophisticated and only a few experts in the world can do. But I hope that today I will convince you that it's not that difficult. And I promise to show you a bunch of beautiful pictures, so please sit back and enjoy them. So if you look at the general concept of the 3D imaging and the volume imaging in general, we can divide the technologies into three big groups. One is the static 3D. So basically, then we talk about the cardiac imaging. So then we are taking the 3D volume of the heart. We are taking the image within the cardiac cycle in the random point within one cardiac cycle. And that represents that particular frame in the 3D. So we will discuss how helpful that could be. So then we have a technology that's called the STIC, Spatial Temporal Image Correlation. And this is something that 3D probe can generate, and it puts the different frames in the order and kind of generate the virtual cardiac cycle. That's why then you can see it on display of the ultrasound machine. You have that cardiac cycle looped, and you see this in motion. And finally, we have the real 3D or 4D imaging. This is when we have the volumes produced over time, and this is a real 3D imaging per se for the cardiac. So all of those modalities can be used in grayscale together with color Doppler, also the other modalities of the color Doppler, and also the V-flow. So what do we need in terms of the image optimization? What parameters should we adjust in order to obtain the best volume? First of all, we need to decide at what reference plane we are going to obtain the volume. And most of the time for the heart, it's either forward chamber view or the sagittal plane that demonstrates at least aortic arch. We need to decide on the acquisition box. So usually the acquisition box should include the whole area of interest, and we need to decide how deep or how wide that angle is going to be, so that we need to adjust the acquisition angle. So also it's important to keep in mind that the quality of your volume imaging is going to be can be different. So the resolution of the STIC or 3D image would be as good as many frames you can include at your volume. And so that's why that correlates to the duration of the acquisition of your volume. So the longer the acquisition, the more resolution you're going to get. But at the same time, there is a problem that the baby being very active and the mobile, that if you have the time of acquisition set way too long, like 15 seconds, you can imagine that you can get a lot of movements, artifacts, in particular if baby is in emotion. So the other aspect of the 3D imaging, other than acquisition, so acquisition is, again, very easy. So, but the most difficult part is the image optimization for 3D imaging display. And here we have pretty much I would say infinite way how we can look at that volume. So the most common types of the image display, so this is usually how the image comes out, then you just acquire the volume. So the most common, this is the multiplanar view, where you can look at the reference plane on plane A, and then at the two orthogonal planes on the plane B and C. And usually if you put your reference point, for example, in the aorta, you can also follow those structures in the two orthogonal planes. For example, here on the plane B, we have the ductal arch plane, and here we have the image of the descending aorta. Another way to look at the volume is the tomographic display. Here we have the volume sliced the step that you can regulate here. So you can adjust the number of slices and the step in between them, how many millimeters you want to have in between. So here is the 0.5 millimeters. And you can look at your volume from top to the bottom. And for example, here we can clearly visualize the situs, we can visualize the 4-chamber view, and we can see the LVOT a little bit, and then the upper mediastinum, the transverse aortic arch, thymus, and the SVC, sorry. Also, we can take a look at the 3D rendering so that we can reconstruct the surface of the 4-chamber view and have the deep view of that 4-chamber, or we can reconstruct the AV valves and clearly look at the leaflets of the AV valves, for example, here. So we can see the anterior leaflet, posterior leaflet. We can see 3 leaflets in the tricuspid valve. Definitely gives much better resolution and understanding of the anatomical structures. We can use the inversion mode of the rendering that presented here that pretty much inverts the black and white echoes, and that also could be used for looking at the cardiovascular system. We can use the effect of the position of the source of light and the different location, and we have 3 sources of light. We can change it so that we can adjust the image the way we want it. So also we can clearly see, for example, this is 2 echogenic foci in the left ventricle, and you can look at them and you can see how the image going to change. Then we place the source of light behind the image or up front. We can combine the acquisition of the 3D imaging, the color, and this is the sagittal plane as a reference plane, and we can see here the reconstruction of the spatial relationship between all the vascular structures. So we can see the aortic arch, the ductal arch, and the bicaval plane at the same image, and usually then we deal with the very complex pathologies, and I showed you this case yesterday that can be very helpful. So the application of these techniques, I'm going to show you a few examples. Then your baby is very mobile, then the stick imaging or the regular 4D volume imaging not going to perform very well due to a lot of artifacts. The 3D static could be an option, and here you can see that we can reconstruct the vasculature at the abdominal level, or we can take a look at the AV canal and demonstrate all the anatomical landmarks, including the common AV valve, the septum primum ESD, and the inlet VSD. We can take the volume and reconstruct the view that usually is not available for us by 2D imaging. And here we can take a look at the interventricular septum from the right ventricle and clearly map the size and the shape of the ventricular septal defect, which is inlet and located right below the tricuspid, the septal leaflet of tricuspid valve. And this is definitely something that we can do, and this is what not available using just 2D. Assessment of the vasculature of the abdomen is very useful. Then you're looking for the different malformations within the circulation between the umbilical vein system, portal vein, and the hepatic veins. And here you can see a few examples how the normal umbilical portal system would look like, and the same in the presence of the very common malformations such as the persistent right umbilical vein. We can navigate where the ductus venosus is connected, and this is a few examples of the normal ductus venosus, and also the ductus venosus that is absent as a direct drainage of the umbilical vein to the coronary sinus. The other point of application, this is upper mediastinum. This is where we can reconstruct different malformations of the aortic arch, such as the aortic coarctation. But in my experience, the demonstration of the vascular rings and different types of the malformations of the aortic arch, that can be very helpful and definitely gives you more confidence in diagnosis of those anomalies. Here we have a great example example of the double aortic arch due to the vascular ring due to the double aortic arch. We can see the right-sided aortic arch and the hypoplastic left-sided aortic arch. Usually 80% of cases, that's what you will observe. Also, we can see the origin of the head and neck vessels that clearly seen here. And also we can see the ductus arteriosus and the kinking and the aneurysmal shape of that structure. And all of this can be obtained in one image, so that for looking at those parameters, you probably need to move up and down in the mediastinum and reconstruct it in your head. But you know, the 3D imaging can give this opportunity and help you to see that spatial relationship. The same we can do, then we look at the right-sided aortic arch, and the most common situation, then we have the right-sided arch to the left-sided ductus arteriosus. As you know, this situation has two scenarios. It could be normal variant, then we have the normal distribution of the head and neck vessels like mirror image, or that would create the issues consistent with the vascular ring, then we have the aberrant left subclavian artery. So this is probably the best way to demonstrate the aberrant left subclavian artery and the distribution of the head and neck vessels. Then you take the 3D volume at the level of the free vessel and trachea view, and then you can clearly see this is a 3 examples of the vascular ring due to the right-sided aortic arch, left-sided ductus arteriosus, and the left subclavian artery that runs on the back behind the trachea. And here you can recognize not just the origin of the persistent origin of the aberrant left subclavian artery, origin of the right subclavian artery, but also origins of the internal thoracic arteries that also helped us to navigate where the thymus is. And you can see that there is a lot of case-to-case variations how you can recognize those anomalies. We talked a little bit thymus in the previous talk, and Julia showed us that this is very important to evaluate, but particularly in the second trimester, it could be challenging. And challenging assessing not where the thymus is, but measurement of the structure and determination of the side borders or the lateral borders could be very difficult. So 3D can provide the thicker slice, and this is how we can recognize very clearly where the lateral borders are. And this is called also a box technique described by Dr. Palladini from Italy, where we have the vascular structures creating like a box for assessment of the size of the thymus. We can see that posteriorly, this is the brachiocephalic vein, and on the side, this is the internal thoracic arteries, and everything inside those vascular structures is thymus. But of course, we can use the 3D static volume measurement of the using the vocal tool, so to trace the volume of the thymus and get the number that basically can help us to estimate the volume more accurately, because judgment of the thymus in one plane not always very accurate. We also can evaluate using the 3D other structures that may affect the function of the heart. Like in this case, we have a baby in the cephalic position, the lever position of the heart, where the entire heart is compressed and found in the left chest. And this is due to the big cyst that is basically, we have the CPAM, the huge dominant cyst. We can observe the size of that cyst. We can drain the cyst and then basically follow up the size of this vascular structure and the size of this cystic structure and that impact on the cardiovascular system of the baby. So we can estimate the volume of the other lungs lesions, for example, like in this case, in settings of the pulmonary sequestration, and we can confirm the diagnosis that this is a sequestration by visualization of that feeding vessel that is very clearly seen on this 3D imaging. In the other anomalies that can significantly affect the fetal heart, the teratoma, sacrococcygeal teratoma, is one of them. And we know for sure that the progressive growth of those lesions may result in the severe congestive heart failure, and monitoring that the 3D volume measurements, this is really effective way to predict the poor outcome as presented here. So moving to the stick or e-stick application, depending on what probe you're using. So I just want to highlight how close the image that you got on the ultrasound to the anatomical specimens, and how much that can help us to evaluate the anatomy and internal surface of the heart. Of course, it's very helpful for the prenatal diagnosis and distinguishing between normal and abnormal heart. And for example, here we had an example of the univentricular heart. We have common atrium, common EV valve. We can clearly recognize that this single functional ventricle is right ventricle in anatomically, because we can see very clearly the moderator band here, and this is a teeny tiny hypoplastic left ventricle that represents the outlet chamber, and we can see also the bulboventricular foramen here. So all of this we can see in one image, and we can get a lot of details here, for example, how the inferior vena cava is connected as well, and we can compare that to the normal anatomy that presented here, and all this can ease the not just the understanding of this complex anatomy of this heart defect, but very often can help you to communicate better with the other subspecialists, for example, pediatric cardiologists and the surgeons, and explain this more effectively to the patients. So this is another example of the EV canal. We can clearly see using stick volume imaging how dysplastic those leaflets are, and no wonder that we have such an enlargement of the right atrium. So we can clearly see why is that, because even without using color Doppler, we can see that this common valve is very leaking, and this is what result in this disproportional enlargement of the right atrium. We can assess the morphology of the common valve. We know that the common valve has 5 leaflets, so the 3D and phase view in the rendering mode can help us to visualize those bridging leaflets, and this is just the reference plane how the normal EV valve is supposed to look like. So we can find a really small ventricular septal defects, and not just to find them, but also map very precisely where they're located. For example, this is a muscular VSD. It's outlet VSD because it's located, in the anterior portion of the interventricular septum, and you will be able to see it only then you're leaning towards the left ventricle outflow tract, and this is because it's located high here, as we can see at the cross-section view of the ventricles, and both of those views we can obtain from one volume, and this is something that is very helpful for precision of our diagnosis. I also find it very effective and easy to take a look at the baby's heart in the first trimester using the 3D technologies. And here you can see how clearly we can visualize the normal anatomy of the heart at the level of the 4-chamber view or at the level of the 3-vessel and trachea view using the stick volume acquisition and using transvaginal approach for that. I would like to highlight that here we can visualize such a tiny vessels as the internal thoracic arteries as early as 12 weeks gestation. So this is like really sensitive method. We can use different presets of color in order to highlight different anatomical structures. Here we have the main focus on the interventricular septum, and here we are focusing on the 3-vessel and trachea view. And just few examples of pathology. This is complete EV canal at 13 weeks gestation. We can clearly see all the anatomical landmarks of this cardiac defect, but what's really remarkable, we can visualize the central regurgitation at that EV valve, so pretty much implying that the crux of the heart is abnormal. We can get more confidence when we are looking at the major problems with the heart, in particular univentricular hearts. This is something that needs to be detected in the first trimester to give enough time to the family to decide what type of management of the pregnancy they want to choose, and start conversation about how we're going to prepare for delivery if the pregnancy is continued. And for example, this is a very tragic case. That patient had multiple attempts of the IVF pregnancy, up to 20 in the course of 10 years. 2 embryos were transferred, and only 1 baby. We were able to see that it's the singleton pregnancy, and of course we did our best to look at this baby from head to toe at 12 weeks gestation, and this is the cardiac anomaly that we detected. So then you have this type of clinical situation, that the history and the pregnancy being that valuable, you absolutely have to be sure that if you deliver such a bad news, that you are confident in your diagnosis. And I think that the 3D definitely help us to make it obvious and improve the communication with the patients, because this is very vividly showing what's wrong with the heart. Another example, here we have the tricuspid atresia, 13 weeks, 6 days. And here we look at one volume, but we can retrieve different levels. And this is at the level of the abdominal circumference. What we can see here? We can see here the descending aorta. And next to that, we can see enlarged vessel, which is the azygos vein. And right away here, we can suspect that this baby also has the vascular problems, such as the interrupted IVC. Going to the chest, we can clearly visualize 3 chambers in the heart. This is the right atrium, the left atrium. Please note that we can clearly see the normal drainage of the pulmonary veins to that left atrium, 1 EV valve, left ventricle, and the right ventricle is missing. And this is because it's tricuspid atresia. The right ventricle is very, very small. You can see the VSD and the blood flow through it. So this is all the anatomical landmarks right in front of you. And again, this is easy diagnosis to make when you deal with these images. The other application that is available on the specific probes, such as the matrix electronic probes, this is biplanar mode. And so here you can see that we can use the advantage looking at the 2 orthogonal planes simultaneously. That can be useful when you're assessing some masses within the heart, and then you can simultaneously look at the 2 planes, like sagittal and the axial, in order to better to describe where that lesion is located. That can be used for the measurement. And also the contrast resolution is really important when we look at the heart, so that can be improved using the volume contrast imaging. In the past, it was available only as a 3D mode, but nowadays we have the technology that allows us to use the 3D probe, but have the volume contrast imaging on the 2D image, and this is how it looks today. And this is completely different type of the visualization that can be achieved with this new technology. So it's hard to believe that this is just a 2D image and you are scanning without any manipulations with the volume. You're just applying this technology, you activate that, and the only thing you need is just 3D probe. You can use the inversion mode as well. Again, it's very easy. And the very tiny and very accurate diagnosis of such as anomalies as the bicuspid aortic valve would not make any problem for you, because you can really see like how easy it's diagnosed when you have that improved contrast resolution. So I would attract your attention to explore those technologies, especially taking advantage of, the technologies being next door. So a lot of things happening in the artificial intelligence, and I just want to highlight one technique for you, that this is the concept of automated multiplanar imaging. Actually was formulated by Dr. Abu Hamid almost 20 years ago. The first publication was in 2004, and this is now that technology evolved a lot, and pretty much every manufacturer of the ultrasound equipment has some sort of the algorithm that allows you to retrieve the reference, to retrieve the diagnostic planes from the 3D volume acquired imaging. So as we said, the reference plane usually should be set up at the 4-chamber view. You need to make sure that you have the very nice axial plane that's completely visible, and then you acquire the angle about 30-40 degrees. This is exactly what you're going to get on the display. Then you apply this imaging, and then the system would ask you to highlight the interventricular septum and place the dot in the descending aorta, and basically after that everything's going to be placed in the certain position by the system along, and the only thing that you need to do is just switch in between the 4-chamber view, the LVOT, the RVOT, the situs, and the sagittal plane such as the bicaval view, ductal arch, aortic arch. So this is the automation, and this is very rapidly developing technologies. And I think that this is something that definitely worth to explore to improve the detection rate and improve the way how you document your images and get, again, extra confirmation in the confidence of your diagnosis. I'm going to leave you with these conclusions. They end the syllables, and thank you very much for your attention.